Welcome back to Clinicians Brief, the podcast, the conversations behind the content. For anyone that might be new to our show, I'm your host, Dr. Alyssa Watson. And in this podcast, I sit down with the authors of our favorite Clinicians Brief articles to get some insider tips on conditions and clinical situations that veterinarians may encounter in daily practice. My guest today is Dr. Hadley Gleason. She's a clinical assistant professor at the University of Illinois at Urbana-Champaign, and she's here to tell us all about the Modified Robert Jones Bandage. Together, we're going to explore the specific indications for this bandage, discuss its benefits as well as its limitations, and dive into a step-by-step process of how to apply this bandage correctly. So I'm really excited to have this conversation today, Dr. Gleason. Thank you so much for agreeing to sit down with us.
Thanks for having me, Alyssa.
So before we jump in, would you mind telling our audience a little bit about your background? How did you end up in Illinois?
Yeah, so I am from the East Coast originally. I went to Penn for vet school, and I originally wanted to be a large animal surgeon. So I did a large animal internship, and then I jumped that ship, did a small animal internship and a surgical internship, and I did actually my residency at the University of Illinois. Finished in 2020, and I haven't left since. So here I am.
That's wonderful. Yeah, I actually started out a mixed animal and I thought I was going to be primarily equine too. And that lasted for about 3 years. And then
It's a tough field. It's a tough field. I empathize with
is.
our colleagues over there.
It absolutely is. So, although I will tell you, I learned a lot of really great bandaging techniques when I was bandaging limbs of horses. And so I feel like I've carried a lot of that over into small animal. So it might be fortuitous for today's conversation.
Definitely. Yeah, I use equine, examples all the time in our lameness exams with the students. So I think there's a lot of crossover that's useful for sure.
Yeah. So what are some of the really common indications for this bandage, for the Modified Robert Jones Bandage?
Yeah, so the main indication is going to be any kind of wound or area that you need to protect if you're not placing a splint. So anything on the distal limb is going to be much better to often place a modified Robert Jones bandage. Just try to stick a Band-Aid or something on there that's going to fall off more likely. It's also really indicated for anything where you're going to place a splint. You need that padding underneath the splint to help prevent sores from the splint rubbing. So that's the other major indication that we'll use it for.
Are there any injury-specific conditions to the extremities where this bandage actually would be contraindicated or you would want to stay away from it?
I think for the most part, anytime you're bandaging, you want to, the only reason to not bandage is if one, you don't need to. So bandages, like we always talk with the students, they're not benign. They can cause bandage sores, as we'll talk about later, I'm sure. So if you don't need to use one, that's an indication to not put one on. Other times I will sometimes, even when a bandage is indicated, I will discontinue use of the bandage if I'm starting to see negative side effects from the bandage. I'm starting to get sores, I'm starting to get, rubs, the dog is getting it wet, the owner is not compliant. Sometimes when those negative things start to outweigh the positive benefits that we're getting from the bandage, I'll discontinue bandage use at that point.
Sure, that totally makes sense because, like you said, they're not always benign. I've definitely seen some pretty bad bandage complications, and we will get into, how to prevent those, hopefully, or at least what to do, when we see them to hopefully make sure they're not getting any worse. Mm-hmm. Do you find that you have some patients that can be more challenging to fit this bandage to? I mean, for instance, if you had a patient that was really obese or, a little dachshund with really short legs, which patients do you find that this can be a challenge with?
Yeah, absolutely. I mean, you already listed off two of them. You think of little dachshunds, corgis, pit bulls with those really big thighs and those little short legs. Those dogs are really challenging to get a bandage on and to keep it on. And so sometimes those are cases where I might be discussing that with the client saying, surgery would minimize the need for you to keep this bandage on. So maybe we consider that more seriously than a dog where we can really easily keep a splint on, keep a bandage on, and make that care, accessible for the client. Cats are always a problem. They want to kick that leg and throw the splint off. So those are probably the main patients that I think we have the most challenges with. And then of course, owner compliance is huge. So owner education, owners understanding that restriction, even though the splint is on, the dog feels good. Any kind of excessive activity is going to make the splint more likely to come off. That's another huge part of it.
Okay. Can you explain the difference between, we're going to be talking today about the Modified Robert Jones Bandage. What what really is the difference between the modified Robert Jones and like the OG Robert Jones, if you will?
Yeah. Yeah. So the OG Robert Jones, which most people, I imagine at this point in time, have probably only seen in like the 80s textbook picture that was on their PowerPoint from school, but it's the one that's really, really big and bulky. So it's basically using the secondary layer, that usually roll gauze, like the big rolls of cotton that you can pull apart, to make a bandage that is so thick that it immobilizes the leg. And so you can imagine that is one, more time consuming to put on. It has a lot more bandage material in it, so it costs more money, and it's not really reusable the way that a splint is. You can take a splint off, change the bandage, put the splint back on, and it takes time to put on. It's bulky for the animal. It's often heavier for the animal. So you have a little cat, a fat little corgi, that's more likely to have that bandage slip and slide down. So that's modified Robert Jones is one that is smaller, uses the stretch material, or the stretch gauze that can kind of go around the leg in only 6 to 8 layers. And then if you want more stability, you can put a splint on that as well, to help with that. So those are the main differences. I really don't see younger surgeons, younger veterinarians using the standard Robert Jones. But of course, if you're in a position where you don't have a splint and this is what you have to stabilize a fracture or something like that, then that's absolutely appropriate to use.
Sure. So you just keep going, add more and more layers, and you can get that stabilization that with our modified technique, we're really using the splint in order to get that stabilization, right?
Correct.
Okay. So when we're doing this, you said, we can have animals with fractures, we can have, animals with wounds, with surgical incisions, things like that are oftentimes going to be painful. So what are we typically using for sedation and analgesia in order to facilitate the application of this bandage?
Yeah, absolutely. So I think that my mainstay on orthopedics, we use a lot of dexmedetomidine, alpha-2 medications, and that's going to be one. They're relatively safe. I know that the anesthesia teams always scare you about the bradycardia and things, but at an appropriate dose and a healthy patient, really extremely safe. We use these in hundreds of animals every year. The other nice thing is that if you do run into an issue, they're reversible. So you can get that patient in for their bandage change, have them really nice and sedate. It minimizes stress for that patient, instead of having to be held down to have their bandage changed. Minimizes stress for your staff having to hold that patient down or struggle or potentially get hurt doing that. And then you can reverse them and they can walk out the door, an hour or so later once they've recovered. And then we'll often combine that with some kind of opioid. So if it's a patient that I don't anticipate to be painful, I'll use butorphanol. Very accessible. I think most practices have butorphanol. Mm-hmm. And then if I do think it's going to be painful, something like a fracture or a wound that we need to do a little bit more debridement on, I'll use a full mu opioid. Methadone is my personal favorite, but really anything that you have is going to work just fine in an appropriate dose.
Yeah, we use a lot of hydro in my practice, so that's what I would be reaching for in that instance. Yeah. So let's talk a little bit about the layers. Okay. We're going to start with that primary layer. That's the one that's going to be, in contact with the skin. When we're selecting that layer, what should we be looking for?
Yeah, so I think it's not so much what you're looking for, but what you want, looking at your wound and trying to decide what am I asking this primary layer to do? So some of the examples that we might have is this wound is still really contaminated. I've done all my debridement, and there's still little bits of dirt, there's little bits of hair that I can't quite get out. That might be a wound that needs continual mechanical debridement. So early in the wound, this might be the only time that we're really recommending an adherent dressing. So you put something in there like soaked gauze that's going to do some, gross mechanical debridement and pull some of that material out. That's very different than a wound you look at. It already has nice, healthy granulation tissue. You don't want to put something adherent on that that's then going to pull that healthy tissue off the wound. So instead, you might be looking for something like petroleum impregnated gauze that's just going to cover the wound, keep it nice and moist, and promote that epithelialization, rather than pull off some of that tissue that we want to keep there and keep healthy.
Okay. And I'll say, oftentimes for me, I'm, when I'm applying these bandages, I'm grabbing, a non-stick, non-adherent, kind of like a Telfa pad, and that's my primary layer, and I'm putting that on. And then are you adhering that in place with anything, or are we really relying on that secondary layer then when we put that on to keep that primary layer where it's supposed to be?
Yeah. Really, the secondary layer is what's going to keep that layer in place and hold it there. And as far as the telfas, I always joke that they say they're non-adherent, but I'm sure you've seen that once that tissue
Mm-hmm.
they get wet and then they dry, they actually are quite adherent. So oftentimes I'll want to use something like a triple antibiotic, something that's petroleum based underneath that to prevent it from adhering to the wound. But I would say the most important thing about bandages is, and I think we'll talk about this potentially later, is changing them at the appropriate interval. You can have the most perfectly selected primary layer, and if you leave that on for too long, it's going to be a problem for that pet, and you're going to have delays in your wound healing. So that's honestly the most important thing. You could pick almost anything, and if you change that bandage regularly enough, you're going to have success eventually.
Good. So, and you had mentioned in the article that you wrote too that there's so many primary layers out there, and that was kind of beyond the scope of that. And we could probably talk about all these different primary layers, and we wouldn't be able to get to the rest of the bandage. But do you have any resources or references where our audience at home can go if they wanted to look at lists of different products that are available?
Yeah, definitely. I mean, there's all the way from, just going back to the textbook, we have our like surgery Bible, so to speak, the Tobias and Johnston. There's a lot of lectures out there. I know that Jaha has some recorded materials on wound care and primary layers. It's an entire lecture just on that. ACVS or any surgery focused lecture, they're going to have a section on wound healing. As far as, other primary literature, of course. So there's a lot of references out there that we'll go through those in great detail. And as you said, there's so many different choices, especially with all the commercial products out there. A lot of them, there's a lot of overlap, but definitely there's a lot of material out there that could be an entire lecture in and of itself.
So let's talk a little bit about stirrups. This is something that I see, I would say in my 20 years of practice, most other clinicians that I've worked with, most other, licensed veterinary technicians really like stirrups. They're placing stirrups, but I see probably 20 different ways that stirrups are placed. So, they have limitations. Could you talk a little bit to, why we're using the stirrups, but what their limitations really are so that we're not expecting them to do things that they can't do?
Yeah, definitely. And I think that's part of, I think in my article, I talk about, I don't personally use stirrups as a first line. I think that's because stirrups, for me, don't fix the main problem that I see with bandages, which is slipping downward from the thigh, kind of like we talked about with those little dachshunds, the corgis. The area where we have trouble is where they're kind of coming down from above, in that inguinal area, sliding down to the knee. And stirrups don't really address that problem. They keep the bandage from sliding off the leg. So one patient population that I do, am a little quicker to put a stirrup on is a cat, because they tend to kind of kick that leg and the whole thing will just slide right off. And stirrups prevent that from happening. But I just don't think they address. Sometimes we're using them for situations where we're not addressing the main problem, which is the bandage is slipping or becoming soiled, but it's not truly just coming off the bottom of the foot.
Yeah, absolutely. Have had those instances where I've placed a really beautiful bandage on a cat and it gets up and it goes like this and my bandage goes across the room. So when you do place stirrups, if you've decided that they are indicated or that you want to use them, like in that cat, does it matter, where around the limb do you place them? I know some people like to place them on the medial and lateral side of the limb, but other people like to place them kind of on the dorsal surface and the paw pad.
I think medial lateral for most people is kind of the number one choice. It's not flexing and extending as much as the dorsal and the palmar surface or plantar surface. But the main thing with stirrups is you want to put them on healthy skin. So let's say you have a circumferential wound, if you don't have healthy skin, then you shouldn't be putting stirrups on. If the tissue on the medial and lateral side is unhealthy and you want to use stirrups, you think they're the right choice, then putting them on the cranial and caudal side is absolutely appropriate. So the main things would be just not putting them on tissue that is either macerated or looks diseased in any way or has any wounds on it.
And you also had a really neat little pearl that when you're changing these bandages and you're using tape stirrups, is to apply the next set of stirrups over the old one so that you're not continually ripping those stirrups off. And so I thought that was, a neat little trick. I hadn't really heard that or done that before. How often do they need to be replaced though? And what are some signs or symptoms that we need to take those off a little early?
Yeah, I'd say about a week or two at the most would be how long I would leave a stirrup on. That adhesive can, one, their skin is exfoliating. They're not adhering quite as well if you leave it on for an extended period of time. And then if the tissue starts to look inflamed or look thickened or have any kind of, oftentimes they'll get that kind of gunk in their feet that will kind of get stuck underneath the tape and around the tape. Just to have a clean foot, sometimes I'll remove them to get a good scrub of the whole foot. But yeah, if you're doing a bandage change often, every couple days or daily, peeling that tape off and putting it back on, you can imagine if you were getting, a wax every couple days, it would start to irritate your skin.
Mm-hmm.
So you want to make sure that you keep that as healthy as possible by preserving that skin interface.
And then we talked a little bit about, oftentimes we're using this bandage with a splint. When we do use a splint, when are we incorporating that in the technique? After the secondary layer, between the kind of padding and the gauze? Where is that splint going in?
Yeah, so you're going to be after the secondary layer. So once you've kind of wrapped your cast padding with your cling wrap, before you put your tertiary layer on your layer on, you're going to put that splint on and then use another layer of cling to hold that splint to the bandage. So you want to make sure that your bandage underneath that is nice and compressed, and then you're placing your splint on after that, and you're putting your tertiary layer on for protection after that splint is on.
Okay, perfect. Yeah, I had just, that is actually the way that I do it, but I wanted to make sure that there wasn't something that I was doing incorrectly.
Nope, doing great.
Life in the clinic is busy enough without wasting time looking for things. The revolutionary new Plums Pro combines our trusted, time-tested drug information with everything you need to get through your busiest days. Subscribe for anytime access to concise, practical monographs covering diagnosis and treatment topics, algorithms to guide your case management, and a library of more than 750 shareable pet owner guides. Plums Pro is fast, easy to use, and always right at your fingertips. We can't guarantee you'll always be able to find a working otoscope head, but we'll take care of almost everything else. Find the clinical support you need the first time, every time at plums.com. So moving on, we're going to talk about the secondary layer now. This is kind of what I think of as like the real meat of this bandage. And this is going to be that cast padding and the conforming gauze like we were talking about. So, and we've talked a little bit about, the roles of this. It helps secure the primary layer, but what else is this layer doing?
Yeah, so this layer is also available for absorbing any drainage from the wound, particularly if you have a really effusive wound. You want to make sure that layer is thick enough that until you get to your next bandage change, you're not getting any strike through, because that's going to allow bacteria to kind of travel down that fluid avenue back down to your wound or your surgical site. So if you don't have a very effusive wound, you just have an incision or something that you're trying to protect from, the hospital environment, it can be relatively thin secondary layer. If you have a really effusive wound, that might be something that's quite thick. And then if you have a splint, you're going to want to kind of balance in between those two, because you want that to be thick enough that you're not going to get bandage sores. You're padding the leg and kind of creating conformity with some of the pressure points, but you don't want it so thick that your splint is actually pushed away from the leg and losing biomechanical stability. The further away it is, the less support it's able to provide to the limb.
That's a good pearl as well. There's lots of different, materials out there, commercial materials out there. And so do you have recommendations on the choice of cast padding? Not so much brands, but size, 2-inch versus 4-inch. And then, there's different cling gauze as well. I know there's brown gauze, there's white gauze. Is there a difference? Is it just the color? I'm embarrassed that I don't know the answer to that.
Yeah, so as far as the sizes go, it's nice to have a variety. If you can only have one, I probably would pick 3-inch, because then you can kind of middle between the two. But it's kind of a pain to put 4-inch on a really small dog. It doesn't conform as well to the leg. You might be able to rip it in half and utilize your stock better that way. But 2-inch is going to be much better for these small creatures, these cats, where you can really get around those corners with their legs. That's going to really take you a long time to use 2-inch to wrap a Great Dane. So it's nice to have the really big sizes for the bigger dogs. As far as the cling, the most important thing is that it has some stretch. So, going back to my equine days, we use a lot of brown gauze because those bandages are on very tight. It doesn't matter as much. They don't get those, the tourniquet effects that we can get in small animals. So, but you're only going to be able to provide the right compression without causing a tourniquet effect if you have a cling gauze that's going to be a little bit stretchy for you.
Okay. And then if, I find veterinarians are so great at Macgyvering all these things. I've seen tiny little, pencil splints in exotic patients and I think paper clips and things like that. So if we do have those tiny little patients, like you said, it's okay to, cut that gauze or either the gauze or the cast padding, into really small strips in order to apply that.
Yeah, absolutely. I often, with my 2-inch, it starts to kind of unravel on you because the roll is bigger than it is wide. And so often I'll kind of cut it in half. I'll use half the roll and then I'll split it up to make it a little bit easier. But yeah, absolutely fine to cut them in half. If you have a really small patient, like a little newborn kitten or something, make it easier on yourself and cut it in half.
And then you talked a little bit about this, what are the primary factors that we're determining when we want to figure out how many layers we're using? So less layers if we have, a non-effusive wound, more layers if the wound is very effusive, and if we don't need to place a splint. Anything else that we've missed there?
No, I think those are really the main things. And I think the thing with bandages, like I said, I talked a little bit about changing them at appropriate intervals, the most important thing. But you're allowed to make changes and make not mistakes necessarily. But if you do something and you're like, oh man, that wasn't enough, the next time you come back, place more, adjust to those indices that you're receiving from the patient, the indications you're getting from the wound, and make changes to what you're doing in real time. Totally.
And, I've always been taught when we're stabilizing a fracture, you want to make sure that you're immobilizing that joint above and below. Is that kind of a similar thing that we're thinking about when we're placing these bandages? Or do you have set landmarks of where you start and finish the bandage on the limb?
No, yeah. So definitely joint above and below is kind of the rule, and you want to follow that almost all the time. I say almost. I think it's important to not be super dogmatic about anything that you do. And this kind of goes back to the first thing that we talked about. So the situations that I'm thinking of are distal radius ulna fractures in dogs. The conventional wisdom would have you go up above the elbow with your caudal splint. The challenge is that sometimes, you get these really thin-skinned dogs, you have a greyhound or something, and you start to get really bad sores on that olecranon. I will sometimes break the rules and come just right down below that area. Because again, if this fracture is distal, the benefits that we're getting from that stability are minimized a little bit with going a little bit shorter, but we're getting a lot of benefit out of not covering up that elbow, potentially causing more sores. So that is still the rule, but it's important to kind of take in the information that you're getting with each bandage change and weigh those pros and cons and make the right decision for what's going to get you the best benefit.
Absolutely. You also talked about in really small patients that when you're placing this layer, you can sometimes inadvertently either externally or internally rotate the limb. So could you explain why that happens and share that little tip on how we can prevent that?
Yeah, definitely. So you'll notice, I'm sure many of you have noticed that as you place a bandage on a little chihuahua, something really small, you'll be wrapping in the single direction with your cast padding. And then when you finish placing that cast padding, the dog's limb has rotated, you're looking at the paw and it's 90 degrees from where it should be. And that happens because there's that friction between your bandage and we're so big relative to them that we're actually externally rotating their leg with each pass a little bit. So what you can do is you can kind of alternate which direction you're wrapping. So let's say you finish your vet wrap, you finish your cast padding, and then you're going to your cling, switch directions that you're wrapping, and that'll actually bring the leg back around towards the direction that it's supposed to face. And you can even do that between layers of, your casting tape, between, whatever you need to do. You can just alternate back and forth to prevent that external rotation. So the most important thing is just seeing that it's happening and making that adjustment in your bandage.
And then you also recommend, going from distal to proximal when you're placing that, and then maybe on the next pass coming back down proximal to distal?
So generally, you want to always be finishing proximally.
Mm-hmm.
So for the most part, anytime you're starting a new layer of the bandage, you want to go from distal to proximal. The reason being, you want to always be kind of pushing any fluid or tension up proximally so that you don't end up with a tourniquet effect. So that's another one of the major rules of placing a bandage. It should always go down to the toes. Even if you're bandaging for something on the proximal radius and ulna, that bandage should still go all the way down to the toes to prevent any tourniquet effect on the foot.
And one of the other things that oftentimes happens is as you're doing that, just because of the shape of, the animal and the limb, you get that kind of conical shape to
Mhm.
your bandage, but you really want to try to avoid that, right? For tension purposes. And so how do you get your bandage more cylindrical?
Yeah. So I sometimes will build up the bottom of the bandage a little bit more, placing a couple extra layers to be able to provide that additional, that even compression across the leg. It's still going to look a little bit conical. You don't want to build it up so much that you end up with like a Robert Jones on bottom and then it's modified Robert Jones on the top. But certainly it can help you with keeping that bandage on and keeping that compressive force even across the leg.
And then we're going to do that conforming gauze. Do you have any tips or tricks on the technique when wrapping that gauze? I mean, oftentimes, with that tertiary layer, we say like unroll it first and then wrap it. How do you personally get kind of even tension along that gauze as you're wrapping that over the cast padding?
Yeah, so I kind of just want to see a little dimple kind of in the cast padding when I go around. It should just kind of compress a little bit. You don't want it to be really super, super tight and kind of squeezing it down, but you just want to take, a couple millimeters of compression of your cast padding is really all that you need. And then if you feel like you have some lumps and bumps, you can always use another layer of your cling to kind of take those lumps and bumps down and get your even compression.
Okay. And then this should be the point where, like you said, if you did have a splint, we would be applying that. And if you did elect to do your taped stirrups, this is where then you would undo those from your tongue depressor and adhere those to the layer before we move on to that final protective layer, right?
Yep, absolutely.
Okay. So the last layer is the protective layer, and that's going to be your, rubberized tape. What's the primary purpose of this layer?
Just to provide some protection. All the other layers are very absorptive, and while the rubberized tape or vet wrap or whatever you have is not totally impervious to fluid or anything, it is better than some of these other materials, and also prevent dirt and grime from kind of getting through to your actual layers of the bandage. So the hope is that that will stay dry the entire time and protect those inner layers of your bandage.
And we always want to, you had talked about this, leave out just the two middle toes, okay, and a hole so that we can take a look at those. What are we looking for that might indicate that we need to take this bandage off and replace it, or modify our technique a little bit the next time we place it?
Yeah, for sure. So you always want to see that just those last two phalanges, that's so you can see those two toenails and leave the toes fully wrapped in. But you want to keep that so you can see if the foot is swelling underneath your bandage. So if those toes are nice and parallel, they're tight together, that means that your foot is probably not swollen. If you start to see a change in where the orientation of those toes, they start to separate or deviate outwardly, that's going to be potentially an indication that you're getting some swelling of your foot, maybe an issue with your incision, maybe an issue with your bandage, and it might be something that you say, hey, I want to change this a little bit sooner than I had planned.
And that leads pretty nicely into complications, which is what we were going to talk about next. We've alluded to specifically, pressure sores, and we're going to talk more about those and ways that we can hopefully prevent those. But besides pressure sores, what are some of the other big ones? That tourniquet effect, like you were talking about. What are some other big complications that can arise when we have an improperly placed bandage?
Yeah, so I think the main thing is one you said, the bandage sores. That's probably the most common thing that we see, even in a really well-placed bandage. We can see these, particularly if the client's not following instructions to keep the dog restricted. Other things we can see, as you said, is the tourniquet effect. In an appropriate place bandage, this shouldn't happen. It doesn't happen. But certainly we can see that with your incision. If your incision's a little bit too tight, that might happen underneath your bandage. Um, Other things are just the bandage not doing what you intended it to do. So if it's falling down and not covering your wound, then that's not doing what you put it on there for. If it's slipping and it's not stabilizing your fracture, then that's essentially, to me, a bandage complication. It's not doing what you intended. It's not stabilizing that fracture. And so it needs to be replaced or changed in some technique way to make it do its job.
Let's talk a little bit more about the pressure sores. Bony prominences are places where we particularly see these. So the point of the elbow, I'll see them around the carpus as well, the hock. Anything I'm missing?
No, I think that's mostly. I see a lot of the carpal metacarpal joints. The accessory carpal sometimes will get a little sore, but the big ones I think are the olecranon is probably the number one place that we start to see sores.
And so that's a place where we can use this kind of donut technique. Can you tell us how do you make these donuts? What are you making them out of? And where are we applying them in order to help relieve that pressure on that bony prominence?
Yeah, absolutely. So the donuts you're making are to try and almost build up the area around the pressure point so that the pressure is more evenly dispersed across that larger area. And you can really use anything. You can roll up some of your cast padding and create a little donut. We often will reuse some of the soft sponges from our scrub brushes. We'll re-sterilize those and cut little holes in them and put them on a pressure sore. If it's a really small creature, you could use a little Telfa pad and roll it up. So really anything you have in your practice you can reuse to kind of create a little donut, a little circular area with a hole just about as big as the point that you're trying to cover. Put it on that after your secondary layer and your cling before wrapping it on with some more cling and then putting your tertiary layer on.
Perfect. Thank you. That was going to be my next question is where am I putting this?
Yeah, yeah. And you can do it preemptively. I often don't, but if you have a greyhound or something where you're like, oh my gosh, I worry about this, you can do it even before they start to get a sore. If you think the bandage is going to be on for a long time and this is going to come up, and then always, be willing to change your plan. If you have a dog starting to get a sore, or you feel like the donut that you're using is not working, potentially use a different material, wrap it in a little bit more, things like that to help adjust your plan as you move through bandaging.
And then let's talk a little bit more about, best practices. You had talked about really, 1 to 2 weeks was the longest you would prefer to keep a bandage on. And there's, I know all sorts of tips and techniques and things that we ask owners to do in order to try to prevent these bandages from becoming wet or soiled. Although I will have the dog that's put its whole limb in the toilet before. So,
Of course.
so sometimes we can't control our patients, but what are some things we can try to control?
Yeah. So I think empathizing with the client and, giving them clear instructions is really important. So making sure that they know that this dog is supposed to be restricted and tell them why, that your dog's going to develop big sores. If you let him run around, that leg is going to be pistoning kind of inside of that bandage, causing a lot of rubs. So letting them know, what's going to happen if they don't follow instructions, I think is really important. And then empathizing with how challenging it is to keep your dog restricted, helping them with some chemical restraint if needed. That's really, really important to the success of your bandage. Like I said, you can do a perfect job, pick the perfect primary layer, place the best bandage. And if the client doesn't meet you halfway, you're going to keep running into issues. Other things, you want to make sure you give them the materials or instruct them on to how to keep it dry. So, we live in Illinois, it rains a lot. So we need, we'll sometimes send them home. If you want to reduce, reuse, recycle, you can use your fluid bags, just make sure they're fully dried out. You can have them tie it on. There are some companies making commercial paw covers that you can use over your bandages. So if you have a client that, is going to have a bandage on for a long time, that might be something that would be worth looking into purchasing for that client. So keeping it dry, making sure that they know that if it is wet, they need to come in and change it, that it's going to kind of cause some maceration and sores on the leg, damage to the tissues if they don't have it changed in a timely manner. Those are all things that you can do to help minimize complications.
Do you generally send clients home with kind of a written list of, bullets? These are when we need to come back. This is what you need to be looking for.
Yeah, absolutely. So we have a little template in our discharges that says, if the bandage becomes, slips down, becomes soiled, becomes wet, if we place a bandage and the dog, or if all of a sudden the dog is suddenly bothered by the bandage, they were comfortable with it and now they're kind of looking at their leg or they can't get settled. Those are all things on there that we say you should call us and come back. If the toes start swelling, like we talked about, you notice them coming apart, we'll often have them send a photo to us so we can take a look. And then, it's best practice in my mind, just if you have any concerns, have the dog come in. It feels way better to have changed the bandage and been like, that was a little bit of a waste of time and materials rather than, wait and see, oh, I think it's fine. The dog comes back and its foot is really swollen or the wounds are looking really gross. You're always going to feel better having seen the dog and made sure it's okay.
Yeah, absolutely. And that's a really good one too, that I sometimes forget about. If they're doing really well using the limb and then suddenly it seems like they're painful again or not using the limb quite as well. Because often, I'm sure you've heard it. We've all heard it. Oh, he's limping, but he's not painful. So
yeah.
Owners they don't always, kind of associate limping with pain. To our frustration sometimes. But if they're suddenly not using it, that means that we should probably get it in and take a look at it.
Definitely.
Yeah. So this was great. This was everything I wanted to know about the Modified Robert Jones Bandage. Is there anything else that I missed that you would like our audience to take away?
I don't think so. I think, again, the main thing for me is if you have a wound, changing it more frequently than, sometimes you think you need. We have wounds and bandages that we change every day if they're having a lot of drainage. And then don't be afraid to adjust what you're doing. If you're seeing that a wound is forming, make sure if you have a caudal splint and a splint is forming, a wound is forming caudally, potentially move that splint to the lateral side or something else. Same thing with the tape. If you notice that there's a wound, on the lateral side developing under your tape, adjust. So don't be afraid to change your plan based on what you're seeing.
Absolutely. All right. Well, most of our regular listeners know at the end of our episodes, we play a little game. It's just a series of really quick would you rather questions. It's just for fun. Would you like to play with us today?
Sure, why not?
Good, excellent. Okay. Would you rather practice without arthroscopy or without radiography?
Arthroscopy. You can do a lot without arthroscopy. You can't do anything without radiology.
Would you rather have all of your students be punctual, but a little disinterested in your lecture, or be perpetually late, but super engaged all the time?
It just depends on how late. If they're still able to take care of their jobs, then I'd way rather have them be more interested. If all of a sudden, things are falling on my residents or on me that, they should be learning or taking care of, then punctual for sure.
And they need to be there. Would you rather invent a new surgical procedure or would you rather discover a novel class of analgesic drugs?
Probably discover a novel class of analgesic drugs.
Yeah, that'd be cool. You could name it after yourself then too.
I feel like you could name it after yourself. I feel like it's probably more lucrative. I could retire and do all the things that I only like I could open my trauma fracture place instead of, so.
That would be great. Would you rather cut only soft tissue cases or only orthopedic cases for the rest of your career?
Only orthopedics, 100%.
Yeah, I figured that was going to be your answer, but I had to throw it in there. All right, last question. If they both existed, would you rather perform surgery on a unicorn or on a dragon?
Oh, interesting. Probably a dragon, I guess. It's more novel. I feel like a unicorn is kind of like a glorified equine surgery, so it's something totally different to do a dragon.
Yep, I would do a dragon too. Although I feel like you'd have to be really careful, especially if it was a fire-breathing dragon with anesthesia and oxygen, might be a little dangerous.
Yeah. Oh, very true. Very true. I'll let anesthesia handle that. That's the beauty of academia is I can just focus on the surgery.
That was a great answer. Well, thank you so much again for joining us. Hopefully our audience really enjoyed this as much as I did. They were wonderful tips.
Thank you so much for having me. I appreciate it.
Thank you all for listening to today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that we have on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or, if you'd like, drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.